All right, future paramedics, one more video here to talk about EKG for this particular session or this particular day of activities. Let me share the screen and let's talk about the basic beat. Okay, so the basic beat, you know some of this already, and you'll remember some of this from your AMP class, but let's be really specific and get into some of the details on the basic beat, okay? So first of all, when we talk about EKG, the basic components of the EKG are wave, segment, and interval. A wave is any deflection off of something that we call the baseline, okay? And we'll define the baseline in just a moment. So wave is anything that deflects off the baseline. A segment is a portion of the baseline, and an interval is an amount of time that has gone by, and it needs to include at least 2 items on the EKG. So it'll include at least 1 wave and at least 1 segment. Sometimes it'll include more than 1 wave and more than 1 segment, but a wave is any deflection off the baseline. A segment is a portion of the baseline, and an interval is a combination of any number of waves and segments combined. If you look down here at the cartoon, at the drawing that you have here, it labels them. I'll go into each one of them. You are probably familiar with the P wave, QRS Complex, and T wave, but there's a lot of other activities in here. So we've got the P wave, the PR segment, what we call the QRS Complex, which can consist of a Q wave, an R wave, an S wave, or any combination thereof. We'll talk about that later. The ST segment, the T wave, and then the baseline from the end of the T wave to the beginning of the next P wave is what we call the TP line. And then we have some segments. The PR segment is from the beginning of the P wave to the end of the PR segment. The QT, that's the PR interval, and the QT interval is from the beginning of the QRS complex to the end of the T wave, and we have some other ones as well that I'll get to. So waves and the baseline. Waves are any deflections from the baseline. We will identify the baseline usually from the TP segment. So from one TP segment to the next TP segment is what will create the baseline. So you remember that ruler I showed you in the last video that had the blue line in the middle? We would set our blue line on one TP segment and run it to the next TP segment, and that kind of tells me where the baseline is. Waves can be single, isolated, positive, or negative. They can be biphasic. They can have combinations of positive and negative components, and we'll talk about all of that as we go. Waves are named in accordance to their size, location, and the direction of deflection. So we'll say they're flipped, or we'll say they're upright, or we'll say they're, this one is related to atrial deflection, or this one's related to ventricular depolarization. But we'll talk about all of those as we go along. The first one is the P wave. The P wave is usually the first item within our, within a cardiac cycle, what we call a cardiac cycle, or the beginning of an EKG system or complex. So it's the first wave of the system, typically. It is the representation of atrial depolarization. Let me be clear on this. We've talked about the autorhythmic cells, the SA node, the atrial pathways, the AV node, the bundle of His, the bundle branches, the Purkinje fibers. The P wave is none of that. The P wave is the representation of atrial contractile cell depolarization. That's going to be important. P wave is, let me say that again. The P wave is a representation of atrial contractile cell depolarization. The autorhythmic cells, even though there's many of them, there's still too few for us to actually see on an EKG. So I'll try to make that clear as we go along. The P wave starts as soon as the SA node fires, or just at the tail end of the SA node firing. It usually is between 0.08 and 0.11 seconds, and normally has a downward and to the left axis, so 0 to 75 degrees. I know that that's kind of foreign right there, but that'll become clear when we start talking about each of these components in more depth. So just kind of file it away for the moment. And so here's our P wave. Atrial contractile cell depolarization. The TP segment is the repolarization of the atria, and it is a wave that we rarely see. It's often hidden inside the QRS complex, and even when it's not hidden in the QRS complex, it's often so slight that we may not see it, or may be very difficult to find it. So the TP segment is a downward deflection. It's a downward deflection in lead 2. It deflects in the opposite direction of the P wave, whichever way the P wave is going in that particular lead that we're looking at. And it often occurs at the same time as the QRS complex, so we rarely see it. The PR segment is the time from the end of the P wave to the beginning of the QRS complex. I will, not to be confusing, but there are some books that you'll read that will note it as the PQ segment. The PQ segment and the PR segment are synonymous. They mean the same thing. Most commonly, it's called the PR segment, and I will almost always refer to it as the PR segment. But don't be confused if you read something where it talks about the PQ segment. It is the same thing. It is supposed to be found along the baseline, and anything greater than about 0.8 millimeters is pathologic. And we'll discuss when that is pathologic versus not. The PR interval represents the beginning of atrial depolarization, so the beginning of the P wave, and it goes all the way to the end of the PR end of the PR segment, and it includes everything in it. And I know this is where some confusion happens, so don't be confused. All of the autorhythmic cells will have completed their firing by the end of the PR segment. The Purkinje fibers are the last part of the autorhythmic system. They will have fired by the end of the PR interval. So at the end of that PR segment is where the Purkinje fibers are done firing, and the beginning of the QRS complex is all ventricular contractile cells. So the PR interval includes the firing of the atria, the AV node stimulation, the bundle of His stimulation, the bundle branches, and the Purkinje system are all included in the PR, all included in the PR interval. I will say that there's a mistake on this page that I didn't notice before, but atrial repolarization often happens outside of the PR interval and hidden in the QRS complex. So please don't be confused by that. I will remove that in the future. I didn't mean to have that there. So the PR interval begins at the beginning of the P wave, and it ends at the beginning of the QRS complex. And the normal duration is 0.12 to 0.20. That is a time frame that you need to be very familiar with. We will be dealing with this time frame in almost all of our EKG classes from here on out. So start committing to memory now that the PR interval is a time frame between 0.12 and 0.20 seconds. If it's less than 0.12, it lets us know there's an issue, and if it's greater than 0.20, it lets us know that there's an issue. The QRS complex represents ventricular depolarization. I already said this, but let me be clear. All the autorhythmic cells have already fired, including the Purkinje fibers, before you see the QRS complex. The QRS complex represents ventricular contractile cell depolarization. So these are the actual muscle cells depolarizing. It has the potential to have a Q wave, an R wave, and an S wave, or a combination of those waves, or singular in those waves. There's many different ways the QRS complex can normally be represented. The Q wave may be present or absent. The R wave is the first positive deflection that we'll see, and after the P wave, and is the first positive wave in a QRS complex, or often the first wave in a QRS complex if a Q wave is not present. We'll talk about each of those waves as we go. The normal duration is 0.06 to 0.11 seconds. and it is critical to note that interval and especially the width of that. If you have a QRS complex that is 0.12 seconds or greater, then we call it wide. And so that's the next set of information you need to start committing to memory is the width of a QRS complex. So the PR interval is 0.12 to 0.20, and a QRS complex needs to be less than 0.12 seconds in width, in time. Normally the axis is about -30 to 105 degrees. And again, those numbers, although they might not mean a lot now, will mean something to you soon. So just kind of file that away for the moment in this overview. And here's our QRS complex. We do have a nomenclature, or the way that we write or label QRS complexes when you're writing them or when you're notating them. Tall or deep QRS complexes are given capital letters, and small ones are given lowercase letters. So if we have a little q, big R, big S, we would expect to see a small Q wave with a big R wave and a big S wave. So when we look at the nomenclature, whether you're using capital letters or lowercase letters tells us the size that we're expecting in terms of amplitude. There's also times that we have multiple waves in the same direction. For example, we'll have 2 R waves. If that's the case, the second wave is given a prime marking, and you continue that on. So you might have R, R prime, R double prime, or R, S, S prime, something to that effect. So R waves, Q waves are not given prime notations, but R waves and S waves do get prime notations. So the Q wave is the first negative deflection after the P wave if the first deflection in the QRS complex is negative. In other words, if the first wave in a QRS complex is negative, then we call it a Q wave. If the first wave in a QRS complex is positive, then we do not have a Q wave. So if the first wave in a QRS complex is negative, then we call it a Q wave. The R wave is any positive deflection in a QRS complex. So the R wave would be the first positive deflection after the P wave in the QRS complex. And then if there's another positive deflection, it would be an R prime or R double prime if there's a second, if there's a third positive deflection. S waves are the first negative deflection in a QRS complex after the R wave. So within a QRS complex, if it's negative and comes after an R wave, then we call it an S wave. If there are 2 of them, then it's S, S prime. So in terms of, so within a QRS complex, it's kind of easy. In a QRS complex, if the first deflection is negative, then it's a Q wave. All other positive deflections are R waves, and all other negative deflections other than the Q wave are S waves. QRS complexes and, or should I say R and S complexes, again, you might have R, R prime, and note the nomenclature. Like this first one you see here are 2 large R waves, so we call them capital R prime. Here we have a little R wave and a big R prime, so we call it little r, big R prime, and so on and so forth. So here in this third one, it's a big R to begin with, and then a little R prime, so it's capital R, little r prime. So that's the way that we see the nomenclature in those complexes. For Q wave, sometimes there's significance in the Q wave and sometimes there's not. The Q wave can be benign, but it can also be a sign of dead cardiac tissue. So Q waves are significant if they are wider than 0.03 seconds. So if the start of the from the start of the Q wave to the end of the Q wave is wider than 0.03 seconds, then we would say that that is a significant Q wave. And if the height, understand the height in this case is a negative deflection, but if the height of the Q wave is greater than 1/3 the height of the R wave, then that is also significant and lets us know there's myocardial damage. Insignificant Q waves are often found in leads 1, AVL, and V6. And that's because the septal innervation often fires first, and it often shows up as Q waves in leads 1, AVL, and V6, and we call those septal Qs. So that's quite common. And quite commonly, we see significant Q waves showing up in lead 3, but it can be in any lead as well. So here's an insignificant Q wave, one that is small and doesn't take much time. And a significant Q wave here is, in this case, this one, from the start to the finish of the Q wave right here is greater than if it's greater than or equal to 0.03 seconds, it's significant. And here, this height of the Q wave is greater than 1/3 the height of the R wave, and so therefore it's significant. And we would say there's myocardial damage done here. The intrinsicoid deflection we'll talk a little bit about later, but it's measured from the beginning of the QRS complex to the beginning of the negative downslope of an R wave. And it again represents the amount of time that the electrical impulse travels from the Purkinje system through the epicardium or to the epicardium. So the normal intrinsicoid deflection, we have the right precordials and the left precordials, so V1, V2, and V5, V6. We have normal times related to those. I'm not going to have you memorizing that just yet, other than for you to kind of file that away as important trivia that we might talk about later when we talk about some of the pathologies, where we talk about whether or not the intrinsicoid deflection is showing a potential problem or not. It can be useful in helping us to diagnose various things. So you don't need to memorize it again right now, but just note what the intrinsicoid deflection is. You don't need to memorize the timing right now in the precordials. Do know what the intrinsicoid deflection is. And again, it's from the beginning of the QRS complex to the start of the downslope of the R wave. And we'll talk more about that as we get into specific rhythms. The ST segment is a critical component of the EKG that helps us to determine myocardial infarction or ischemia. It should be a portion of the baseline at the end of the QRS complex to the beginning of the T wave. It should be on the baseline. If it's not, if it's above the baseline or below the baseline, that tells us that there's pathology involved, and we'll have to pay attention to that. And the point where the ST segment begins is called the J point, and the J point is critical for us to identify. And in fact, if we can't identify the J point because we can't find it, that also tells us something. So the J point should be something that we can find, and it begins the ST segment. Any ST changes, any ST elevation in a symptomatic patient should tell us that there is myocardial injury or infarction happening. So the ST segment is a really important portion of the EKG for us to identify and be able to quickly find pathology involved. The J point again being that start of the ST segment, and ST elevation and depression is determined by where the J point is. So sometimes we'll have an ST segment that might be starting above the baseline but ending below. It's where it starts that tells us if there's elevation or depression. And then the T wave represents ventricular repolarization. The T wave is the wave that follows the ST segment. A normal T wave begins in the same direction as the QRS complex. We'll talk about why. And it is asymmetrical. It should be asymmetrical. So the first part, the rising part, kind of goes up slowly, and then the latter part drops faster. So the first part rises or drops. It depends on if the T wave is upright or a positive deflection or negative deflection. But the first part is a slower, longer slope, and the second part is a faster slope. And it should be asymmetrical. Often we'll talk about why the T wave tends to be in the same direction as the QRS complex, even though it's a negative wave. But again, it has a rise that is more gentle and a fall at the end that is faster and more rapid. To assess the symmetry, we typically find the peak. This can be somewhat difficult if the ST segment is not where it's supposed to be. But you can again use our ruler with the blue line to cut the center of, or cut the peak of the T wave. And if you're cutting the peak of the T wave and the two halves of the T wave are the same size, then you have a symmetrical T wave. And typically a symmetrical T wave is a sign of pathology. The QT interval is the interval that starts with the QRS complex and ends at the end of the T wave. So it includes all of the waves of the QRS complex, the ST segment, and the T wave. It represents everything related to ventricular depolarization and repolarization. So it starts at the beginning of depolarization of the ventricles and ends at the end of repolarization of the ventricles. The normal duration is about half the R to R interval. So from one R to the next R, or from one QRS complex to the next QRS complex. It is actually different, it's variable. So it's just normal for it to be less than half the R to R interval. And a prolonged QT interval is a sign of a pretty serious problem. But finding the exact QT interval requires a calculation process and a corrected QT interval. It has to be corrected for the heart rate. So we'll talk about how to calculate the QT interval at another class. So right now, just know what the QT interval is. So it starts at the beginning of the QRS complex and goes to the end of the T wave. A U wave is often, or in some people, a very small and sometimes very, very difficult to find wave that happens after the T wave. It's usually very slight. We don't know for sure what it all represents, but we do see it in a lot of electrolyte disturbances. It can sometimes cause some inaccuracy when we measure certain things like the end of the T wave or finding out the measurement of the T wave. The QT interval can be messed up if we don't correctly find the U wave and make sure we don't include the U wave in that interval. Sometimes it can make the TP segment difficult to find, so therefore the baseline can sometimes be difficult to find. So we need to note the presence of a U wave and then note that it might make analyzing the rest of our EKG a little bit more complicated. Some additional intervals just to be aware of. The R to R interval is a measurement from from one QRS complex to the next. We often refer to it as an R to R interval because the R's are easy to find, but you can measure from Q to Q, S to S, beginning of QRS complex to beginning of QRS complex. We just have to measure from the same spot in the QRS complex to the same spot in the next QRS complex. And often the easiest way to do that is an R to R or S to S. And the P to P interval is from one P wave to the next. Again, from the same spot, either the peak of the P wave to the peak of the next P wave, or the beginning of the P wave to the beginning of the next P wave. And in most people, the P to P interval should match the R to R interval. And that's because the PR interval should match the PR interval of that same person. And we'll discuss more about that as we analyze. So there you go for the basic beat. I think that's enough EKG for now. The next thing we'll do is get into how to analyze an EKG. I'm going to talk about the initial process of analyzing an EKG. I'll want you to use that method of analyzing every single time. You'll find if you're really systematic about how you analyze an EKG, then you'll have less problems actually figuring out what the rhythm is. If you try to kind of crapshoot it and not really have a good systematic approach to EKG, then it can be pretty challenging. So our next segment will be how to analyze an EKG, and then we'll get into looking at some specific single lead EKGs. Okay, thanks, and I'll see you soon.